Hello, my name is Dr. Nick Maleska. I'm the current Regions EMS Fellow. I'm joined by a couple of people today that I'm very excited about. I was a resident at Regions Hospital previous to this for my emergency medicine training. And during that training, we receive a lot of information and practice scenarios on how to deliver bad news. And the very people who taught me what I know how to do today are joining me today. And those people are Dr. Karen Quade and Dr. Callie Schnicker. I'm super thankful that you're here. Thank you for being here. And so these people are emergency medicine physicians practicing primarily at Regions Hospital. And in addition to that, they are board certified palliative care physicians. And so they receive specific training on palliative care. And maybe before we go on even further, maybe Dr. Schnicker, you could talk a little bit about what palliative care is as a specialty.
Right. So palliative medicine is a specialty within medicine that addresses symptom management and goals of care, both for people who potentially have curative diseases, but very commonly it's people with chronic progressive illnesses like heart disease, cancer, kidney disease, lung disease. And it can be for people that have curative diseases, but it's often for people who have, progressive life-limiting illnesses. And at the kind of back end of palliative medicine, it does encompass hospice. So hospice being for people who have, in general, 6 months or less of life left.
And so with that, part of that role and part of our training that we get in residency, both as emergency medicine doctors and some of our time in the ICU, is delivering bad news and telling families that we're worried about your loved one at the very end of their life and delivering the news that their loved one has died. And so maybe to set the scene of all of this training, when you are doing this in the hospital, there are some clear differences than the pre-hospital environment. But in the hospital, you are all recognized as the experts in delivering bad news and telling families that there has been something tragic happening. And so maybe understanding that there are going to be some differences between the pre-hospital environment, maybe in somebody's home, maybe in a skilled nursing facility compared to the hospital. Could you talk a little bit about your philosophy on maybe who should be in the room when that type of news is delivered?
Sometimes it's decided before you even get there. So somebody's already in the room and you haven't got a choice on it. Always want to have the key people there. You don't want to have the spouse to hear about it from somebody else. Mm-hmm. So spouses are definitely people I like to have in the room. And if it's an older person and their adult children, I definitely want the adult children in the room. Siblings, true as well. When it's a child, I think it's harder. I don't think that there should be very young children in the room for this. This is something we got to get the adults through first before the children get the message. So when you're actually telling bad news, if there's children, specifically younger children, I would be very cautious about that. Now, it's harder when you have a teenager because teenagers seem to mature so much earlier now than they used to. So it's hard because it's hard to tell a 15-year-old to get out of the room. Mm-hmm. That's pretty much a guarantee they're going to stay in the room. But and then we want to set the scene as much as we can when we're taking care of these patients. Sometimes we have people in the room for resuscitations, but when we're going into a separate room where they haven't seen anything, you want to know who's in the room. So you know who you're talking to. And you want to not just know the name, but you also want to know their relationship with the other people in the room. You want to use the name of the patient. So you don't want to refer to he or she without saying John or Mary, whatever the name is. Excuse me. So that you personalize it as much as you can. I think it's a good idea to very quickly understand what they already know has happened, but don't spend a whole lot of time on that because it sometimes feels like you're stalling, and then you want to get to whatever the ultimate message is. So if the person has died, you want to get there pretty fast, but you don't want to just drop it. And as we talked earlier, I've done it pretty much wrong, as many ways as you can do it wrong. There was a patient that I went in and I said to the loved one, the wife, he's gone. And she responded, where did he go? And I then realized that she didn't get it. So I said, well, he passed. And then she said, passed what? So then I said died. And it is a really good idea to use one of the D words, died, dead, death, something in that term. Especially with so many people not speaking English as their primary language, there's some nuances there that they'll miss. So I learned from that experience, and then a few times later, I had a patient where I said to the spouse, I just quickly said he died, and she literally jumped up and yelled at me. That was blunt. It was like, I can't quite figure out what the right thing is, but I think the point is that everybody's reaction will be a little different, and it doesn't mean you did it wrong. But try to be direct, try to use simple language. Try not to use a lot of medical jargon is the other thing. So I don't say we defibrillated a patient. I'll say we gave him lots of medications. We did CPR and we shocked him a few times, but we were unable to restart his heart. I'm sorry, but John died. Mm-hmm. That's a nice, direct, short, sweet, as sweet as it could be, way to deliver the message. You've given a lot of information. You've given them a little bit of a warning that it's not going well. We talk a lot in hospice and palliative medicine about a warning shot, sort of saying, I'm really worried, things aren't going well. That's very important. I think when the family is actually physically in the room, one of the nuances for those are that you might want to narrate your care a little bit more. So you're working, and as a team, you all realize it's not going well. But of course, the people observing do not know it's not going well. And so saying, guys, I don't see that we're getting any response here. We've tried this, we've tried that. We're not getting his heart started again. Do you have any other ideas? And giving that sort of a warning shot to literally the audience that's watching this can be very helpful to them because they don't understand whether things are going well or not well. And on TV, everybody who gets CPR gets right up and starts talking. So it's all very fantasy in their world. And then saying something to the effect, well, I think we should call the doctor and see if the doctor has any other suggestions. So medic control sounds good. I get that's the phrase, or something similar, but patients don't understand. They want to know that there's a doctor actually here helping to make sure that we're doing everything. And then sometimes body language can be very helpful. As I said earlier, I had a situation in which I literally walked into a room and just shook my head, and that's how the whole family learned that someone had died. And so if you're on the radio and the doctor's saying, yeah, you can call this at the scene, you can shake your head at the family because it kind of gives them a warning, a preparation for what's about to happen. Because usually these are very sudden events, and so they're not very prepared for this. And there's so much emotion to it.
You brought up a lot of really good points there. And one thing that I maybe want to talk a little bit more about is having family present or not present in those sorts of circumstances. When you're in the emergency room, you have a resuscitation room, we have waiting rooms, we have different spaces. Mm-hmm. In a scenario where maybe a family was very upset or they were causing a delay in the care of a patient, how do you decide which people should stay in the room, which people should go into a different room than where the patient is? And how do you have that conversation about what's going to happen?
Right, I think, obviously your safety is a priority, right? If you have serious concerns about your safety or the safety of your colleagues, I think you ask those people, you have to ask those people to leave. At the same time, recognizing that this is an incredibly emotional, shocking event for most people, right? These are sudden events that, maybe mom or dad was sick, but they didn't realize quite how sick. And so this came as, a big shock to them. And, aside from your safety, I think something that's worked well for me that has helped with de-escalating these situations is responding to that emotion and flipping it. So oftentimes people in these situations don't express the feeling that necessarily they are experiencing clearly, right? It can come across as, anger. And sometimes we get in a bad place by responding to anger with anger or defensiveness. Whereas, in our training, we were taught to really flip those negative emotions into positive emotions, right? To flip anger into love and concern. So if somebody's yelling at you, say, I hear you. I can tell how upset you are, and I can tell how scared and how concerned you are. We are concerned as well. We want to do the best thing possible for your loved one. We want to, we are trying as best we can. And I find that is very helpful, right? That responding in a positive way to, a quote unquote negative emotion can kind of flip the scene.
And I think, Dr. Quade, you were talking a little bit earlier about how oftentimes in the EMS world, we rely on our law enforcement colleagues to make sure that the scene is safe. Maybe you could talk a little bit about a scenario or your thoughts on using that language to help de-escalate a situation in the context of potentially causing secondary trauma or causing some increased grief for the family if law enforcement were to forcibly remove them from a scene for safety reasons.
So as I said, I've seen a lot of bad situations. So recently I had a situation in which there were 3 people we had to tell the patient had passed. One person just literally stared at the ground. One person hyperextended themselves and started screaming and flailing. And the third person actually punched the wall so many times their hand was bloody. So people react very differently. But I've also seen, years ago, I had a situation in which a child about 8 years old had come in with trauma, and all we knew was that it was trauma. And the child was pronounced, and I had to go tell the parents in the family room. And I went in, they were sitting there very concerned and tearful, and there were 2 police officers in the room. And I got through I'm really sorry, but I need to tell you that he died. And immediately the police officer stood up and Miranda'd the father of the child. And then the mother just started screaming, and it was just a horrible scene. And I felt like we could have given that guy just a little more time to process before we did all that, and it would have helped the woman as well. Not that it wasn't a horrible situation, but I think there's sometimes secondary trauma associated with these sort of events because we don't know. If you don't know what's going on in the background, whether it's a crime occurring or if it's suicide, you don't know enough of the details, it can be very challenging to do these death telling, which also affects us and our well-being as well.
And same as in the hospital, it's the same in the pre-hospital environment. It is not our role as medical providers to decide how this person died. Certainly we consider it as we're resuscitating the person, and it might change what we do or don't do as we're resuscitating them, but ultimately it's our goal to take care of the patient and inform the appropriate people. And using our law enforcement colleagues to help make sure the scene is safe is important. Also recognizing that they may or may not be an appropriate person to kind of do that narrative telling that we were talking about, allowing them to be with family, especially if they have some EMT or paramedic background. And then conversely, understanding that once we leave, the scene will become one of a crime scene. And so understanding and preparing the family for that is really, really important. So this section on our curriculum is a more formal education via PowerPoint about how to give an organized death notification and specifically geared towards EMS. I want to recognize my colleague Jennifer.t.shea, who has put a ton of work into this along with myself, and so I'm hopeful that this will be well received. So some objectives for today's talk. We first and foremost want to formally train pre-hospital providers how to deliver bad news. This is something that happens frequently. There's over 200 times in a year where we have no transport cardiac arrest just within our service area. And so this is very timely and important for our providers to understand. Also with that is understanding the implications of death notification. I'll show you some research articles during this presentation about the burnout and some of the event processing that occurs and how this might change the longevity of a certain medic or EMT within their service. Also understanding empathetic communication. So often we're geared as clinicians, and this is something that will change and put us back into a human mindset of how we would feel if we were in that person's shoes. We're going to give you a template called the grieving template to use a formal format of how to give this notification. We're going to talk about a few of the common pearls and pitfalls of death notification, and then as part of all of this, we want to assess the efficacy of education through the surveys that you received, and we'll fill out afterwards as well. So starting with a couple of studies, the one in the top right, death notification training for pre-hospital providers. This was a group of about 45 medics that went through training that found some significant benefit, even from a short course of training on death notification. We recognize that this isn't something often covered in your regular curriculum to get your licensure and certification as an EMT or a paramedic, and that's why this is super important. The second one, I want to highlight the Association of Death Notification and Related Training. This one is done by Dr. Abe Campos. Many of you may remember that name. He was a former EMS fellow through Regions. This is an article that talks about the need for formal training for pre-hospital providers, and it even suggests that maybe doing this sort of training and giving medics and EMTs a better understanding of how to do this well might actually decrease burnout in the long term. So what do you do when you're getting ready to tell somebody some pretty terrible news? So the first thing is to pause and collect your composure. This adrenaline type scenario, you're working on a patient, you've maybe been sweating, you maybe had to perform CPR for a while, your heart rate's going. So take a moment to just pause, collect yourself, collect your composure. The next point is remove PPE as you are able. Of course, scene safety and your safety are more important than anything else, but if you can, remove the gloves, remove your mask, remove your eye goggles, those sorts of things, so that you can really connect with the person you're going to talk to. And then part of pausing to collect your composure is getting ready to switch from a clinical mindset to an empathetic mindset, switching back to a person first and a provider second. And the last thing is to have a plan. How am I going to deliver this bad news? And I think the point of today's training is to give you that tool, and that tool is the grieving mnemonic, which we'll discuss later. So empathetic communication is something that's really, really hard, and I think it's even more difficult in a scenario where you have to be empathetic so much. There's such a thing as empathy fatigue, and it's tough to feel for other people all the time. But empathetic communication and being empathetic is showing an ability to understand and sharing the feelings of another. Being able to put yourself in their shoes. Imagine if it was your loved one there that had been recently pronounced, and how you would feel and how you'd want someone to address you. And then empathy, the ability to understand and share the feelings of another. Some of us have gone through death of a loved one, some of us haven't. But I think having the understanding of what they might be going through helps us to be a more empathetic provider. And taking that a step further, you can feel that, but how do you convey the feeling of empathy? So recognize that there are strong feelings in this. They might be angry, they might have grief, they might be disappointed, they might have guilt. And so recognizing and calling those emotions to the forefront and letting them know that that's normal, that's okay. Pause to imagine how the patient or family might be feeling. This is part of collecting your composure and something that should be done frequently throughout your explanation. Understanding that the family is expressing these feelings, and again, as I mentioned, calling them out. I can imagine that must be so difficult. It sounds like you're really upset. I can see how much you cared for your loved one. Simple phrases like that, understanding that they're angry, it shows them that you're listening to them, but it also helps them contextualize why they might be feeling that way. And that's part of legitimizing that feeling, letting them know that this is normal. I can't imagine what you're going through. It's such a hard thing to do this right now, and I really am sorry that you have to be a part of this. Respect the family's efforts to cope. That means that sometimes you need to be silent. Sometimes the families are going to cope in different ways. Sometimes they're going to cry loudly. Sometimes they're going to be very stoic. That might be a cultural difference. That might be just the way that family works. And so respecting their family's effort to cope in whatever way they seem appropriate. And then offering support and partnership. I'm committed to work with you to help you with the next steps. Let's see what we can do together. I'm happy to answer more questions for you. The police will be here soon, and they can help answer the questions after we've left as well. Simple phrases like that lets you know that you're partnering with them, that you're committed to helping them through this difficult time. So now I want to introduce the grieving mnemonic. This is really a format or a template that you can use to deliver bad news. So the grieving mnemonic was originally designed for emergency medicine residents to give bad news in the emergency department, and so it's not much of a leap to transmit this to the pre-hospital setting. But each individual word or letter, stands for something, and so the purpose of this is to really give you a format. The why is death notification is very difficult, and because it's so difficult, there's burnout implications in these situations. It's not necessarily that death itself causes burnout, although there's been some studies that does state that. The actual delivering of the bad news can have significant burnout complications, and sometimes the difficult part of that is the family and patient dynamics, and it's really, really hard to deal with those things, but having a format helps you maintain your composure and focus all of your brain power on kind of dealing with those dynamics rather than having to figure out what am I going to say next. There's other things like unexpected death, pediatric deaths, and families that want to continue efforts that, again, makes it super difficult to be empathetic in that time and to know exactly what to say. And so this sort of unloads the cognitive burden off of you and makes it easier for you to say what you need to say to give an effective notification. We believe that this is positive for both providers and family. Again, there's been implications that this helps with burnout long term, and there's also good data that shows that families feel better and they have less PTSD long term when the death notification is done appropriately. So we're gonna go through this letter by letter. The first G is gather. So this is gathering the appropriate people that need to be there. Family, friends, neighbors. Offer to wait for others to arrive within a reasonable time frame. Offer to call somebody, and something as simple as, is everyone here that would wanna be here? Can I help you call someone before we talk? Sometimes people don't want anybody else to be there. Sometimes they're the only family member, but sometimes they really want somebody besides a provider to be there to support them in this time, and that's okay. I think asking to call, put them on speakerphone, those sorts of things can be really helpful. So G is gather. R is resources. So this is making sure that the right people and the right resources are being activated after the family. So one of the points is family, but also sometimes you might need an interpreter. Maybe you need law enforcement that's happened in a home, medical examiner, chaplain, spiritual leader, whatever that family might need or whatever that scene might require is super important to get moving early. So something like, I called dispatch and the police are on their way. The patient's daughter and her husband are in the kitchen, and they mentioned they had called their stepmom and priest. The captain and I are gonna go talk with the daughter now and deliver this sort of news. So this is a conversation often that happens with outside of the family's presence and making sure that all of the important pieces are already put into place. So R is resources. This is the first part where you are going to talk with the family. So I is identify. Identify yourself, your partner, anybody else in the room that is going to be part of the medical team, and your roles. It's also really important to identify the patient by name. It's not your loved one, it's not your dad, it's not your mother, it's not he or she. The best way to do this is to identify their name if you know it. And then identify the family's understanding of the situation. What do you understand so far about what has happened? And then identifying exactly what it is that you're going to be telling them. And what you're going to be telling them is bad news. This is what's referred to as a warning shot. It's really, really hard to go into a room and say, hey, so-and-so died. It's nice to have a little bit of a lead-in, a little bit of a wait that they are expecting some bad news, and that's all part of having a warning shot. So it might sound something like, hi, my name is Dr. Nick Maleska. I'm a physician with Regions EMS. I was here during the care that was provided to John. What do you understand about what has happened so far? And then you would pause and allow the family to give their response, and you can either say, yes, that's correct, or offer correction. Unfortunately, I'm afraid I have some bad news, and I'd like to explain everything that has happened. So again, that's the warning shot, understanding that you're identifying it's bad news, and now you're offering to identify some more information and explain what has happened thus far. Understand that sometimes asking for their understanding about what has happened so far may not be applicable for that particular situation. It's possible they were there witnessing the entire arrest and someone was narrating what was happening, and so it might not be appropriate to ask them what their understanding is so far if somebody has been keeping them up to speed throughout. So I is identify. E is educate. So people that you are notifying, they need to know what has happened so far. And that's part of understanding what they know so far, so you know where to pick up. Mirroring their words, avoiding jargon is super important, meaning instead of saying I defibrillated your father 3 times, we shocked his heart to try and restart it, is much more understandable for a lay audience. Moving slowly through this, you're gonna give a lot of information and their mind is already gonna be in a heightened state, and so it's gonna be difficult for them to comprehend these things. So sometimes you need to move slowly, and maybe you've had to explain so much you need a second warning shot. So this might sound something like, a family member may say something like, last time I saw my dad, he was normal. I left to get groceries and come back and saw these flashing lights and emergency vehicles outside. Now you know exactly where that patient's coming from, or that patient's loved one is coming from, and you are able to pick up from that point. Well, we got a 911 call because your dad's heart stopped and he stopped breathing. We've been here for 30 minutes, pushing on his chest, giving him CPR, giving him medications, shocking his heart, and doing absolutely everything we can to try and get his heart restarted. We also called the doctor on the radio and asked them to give their input. So this is education. We're just laying out what has happened so far. So E is educate. V is verify. So this is the most important part that I think is that families need to hear, and sometimes one of the most difficult part. They need to know that their family member has died. You need to use a D word, dead, died, not something like passed on, not gone to a better place. So it might sound like we did absolutely everything we could. Unfortunately, despite our best efforts, John died. V is verify. The next underscore is for space. So after telling somebody that their loved one has died, just say nothing. Allow for that silence, and it's very, very uncomfortable sometimes. They might be crying, they might be sobbing, they might be wailing, and you might want to fill that space to either help yourself fill that awkward tension, or also to help the family cope. In most cases, what they really need is just a moment to grieve. So the underscore is for space. After you've given the appropriate amount of space, I is for inquire. So take the time to answer questions, answer them to the best of your ability, and make sure that the family understands what has happened. So you might even hear a hitting question like, I don't even know what to do with a dead person. That's your cue to sort of clue them in that the police are on their way and that they can help you decide what happens next to the body. In a total phrase, it might say something like, again, I am so sorry for your loss. Are there any questions I could answer for you or things I didn't explain well that I can clarify? This is just a nice way to let the family know that you've partnered with them and that you're there to help support them through this and answer some of the logistical questions. So I is for inquire. N is the nuts and bolts. So this might come up during the question section. They might not know what to do. They might not know what they don't know in some ways. And so you may have to clarify these things. And so it might be something like, because John died at home, the police have to be notified and they are already on their way. You can go be with John if you choose. There will be a plastic tube in his mouth and some medical devices on his arms and legs and chest. We aren't allowed to touch or remove any of these devices right now. The police will tell you if or when it's okay to do that. Once the police arrive, the EMS team will leave and the police can answer any further questions you might have. This is setting the family up logistically for what happens next. Many people have never had somebody die, and most people have never had somebody die in their home, and so they might not know what to do next. And so N is the nuts and bolts. G, now I want to make this very clear. This is included in the original publication and included here for completeness, but this is not something that medical direction recommends. The original publication recommends giving your contact information to the family for future questions, but in the pre-hospital setting and for this training, we believe that this is not appropriate, and therefore this is only included for completeness sake. So some tips to do this well. So ideally, notifying in pairs is nice, and it might be nice to have somebody who was less involved in the resuscitation. The person who just got finished doing manual CPR for the last 30 minutes on and off already has a fast heart rate, they're sweating, they're tachycardic. It might be not the ideal person to go involve a very difficult empathetic discussion with. Make the notification direct and empathetic. So don't spend too much time telling them about what happened. Get right to the point and still be a person first and a paramedic or an EMT second. Plan enough time. So make sure that you have enough time. You didn't just sign yourself up for another run that was in your area that mutual aid is maybe coming to take. Make sure that you have the time to sit down with the family and appropriately give the notification. Allow for silence. That silence is really, really hard. And it's important that you sit with the family and the loved ones if you can. Or if the family is standing, maybe it's appropriate for you to stand, but certainly we would never want anybody to hover over the top of family. Make eye contact. Have a plan, use a format like the grieving mnemonic so you understand exactly what you're going to say going into this. It can help clear some of that cognitive load and allow you to deal with those difficult situations. And then another pearl that isn't necessarily formally related to giving a death debrief, but this is about the situation and the setting. Clean up the wrappers, improve the modesty of the patient as you're able, again, within the legal confines of not removing medical devices, but cover the patient with a sheet. Their patient is almost certainly naked at this point, and so protecting that patient's modesty, this might be the last memory that they have of their loved one, and making the scene as close to what they would recognize as possible is appropriate. Some common pitfalls that we see and that people learning to do this for the first time often commit. So failing to calm yourself after the resuscitation. It's easy to go in there and talk 100 miles an hour, but really the family, they're just getting into this, and this is a very difficult situation. So talking too fast can often lead to talking too much, giving too much detail or using jargon. These are all things that make it a more difficult thing for the family to understand, and you're gonna have difficult follow-up questions because they don't even understand what you said the first time. Not pausing for silence. This is so common. All we want to do is make people feel better, and often we relate that to just talking more. Failing to give a warning shot. It's very blunt to go in and say someone died without actually letting them know that you're worried or that you're concerned that they weren't going to survive in the first place. Leaving before questions are answered. These are difficult because questions can arise over time. And so I think simply asking the family, are there any other questions? That suffices the appropriate requirement to answer those questions, but recognizing that more questions may arise and letting them know that police officers and maybe the medical examiner will be on scene to answer further questions for them. Avoid euphemisms. You need to use a D word. D as in dead, death, died, something that is very clear and direct. Don't use passed on or better place. The other thing is using a poor environment. Standing over a loved one or standing over the patient who maybe is in an inappropriate degree of modesty, maybe in an area that's very loud where the family can't hear you. Maybe you're standing on the side of the road and it's super loud and you're just not able to appropriately convey those things. Go to the back of the ambulance, go to a different room, make the patient more modest, make sure that you're at the same level as the family. Make it as ideal of an environment as possible depending on what you're working with. Talking about difficult times, you mentioned an 8-year-old. That is one of the worst things that we have to do in our job, both pre-hospital and in the hospital. Mm-hmm. Can you talk about some of the considerations or some of the things that you might think of or do differently with telling parents that their child had died?
So my concern is always for guilt. Mm-hmm. If it's a sort of crib death or sudden infant death, or accident where a child runs out in the street because mom or dad is distracted by something else, a burn, those sorts of events are just laden with guilt. Mm-hmm. And so I would assume if you're doing a resuscitation on a child that someone's going to feel guilty later. I shouldn't have left it with this babysitter. I should have done something different. I should have taken the child in sooner to the hospital. And try to be sensitive to that and be cautious about what you say. And I tend to err on the side of telling them, even if this had happened in the hospital, I think we'd be in the same situation we are now. Mm-hmm. Whenever I can, obviously a car accident's a different thing, but I think there's always going to be some guilt there, and to try and recognize it and do whatever you can to sort of minimize any potential for guilt in those situations. How about you?
Dr. Schnicker, do you have any other?
Yeah, and I think minimizing any possibility of secondary trauma, right? If they're, again, getting back to, causes of non-accidental trauma that we may see, not passing any of that judgment off. It's, as a parent, as a human being, these situations are incredibly difficult. And it's hard to not, be emotional, especially in the pre-hospital setting where you're in the home, you see their bedroom, you see pictures on the wall, you see the environment that they're living in. I mean, it's tough when we care for kids in the emergency department and we may see kids that come in wearing clothes that our kids wear or mm-hmm. toys that our kids have. I can't imagine how difficult it is in that home. But, coming off of that, acknowledging for your colleagues how difficult that is, and especially checking in with them after these situations. So not only secondary trauma for the parents when you go through this, but, additional trauma for the providers, the EMS crew, the police, recognizing that, these are horrible cases. Mm-hmm. We do big debriefs in the ED anytime a kid dies, or there's a bad trauma involving a kiddo. And those are generally very emotional. We see this a lot, and yet we still, I can't remember the last kid I pronounced where I didn't leave and cry. And I think normalizing those emotions, because, otherwise this is going to eat you up and you're not going to be able to continue to, help the next kid, the next person.
I know in my residency, the hardest person I ever had to pronounce was a 18-month-old. Mm-hmm. My oldest, now 2.5-year-old, was 18 months or thereabouts at the time. And so the similarities, that was one of those times that, not thinking about it, maybe I wasn't the right person to go tell them mm-hmm. that their loved one had died. I was in charge of the resuscitation, and so that sort of makes me the person. But recognizing, I think, in your colleagues, who might be a person who's more sensitive to that? Do they have young children that age? Mm-hmm. A staff physician during my time also went and helped me, a member of the staff who's been there for a very long time, a young person in their teens had died from a violent crime, and so they took that really hard. And so the dichotomy there, that our children are that age, and recognizing that might be the wrong person or the less optimal person. If you don't have a choice, sometimes you don't have a choice and you have to go. But I think sometimes in the pre-hospital environment, we have extra people on scene that can maybe be there with you and help guide that conversation, make it a little easier on the person that might be more affected by that.
And I think, showing emotion in these situations. So in general, when I break bad news or I, tell family members in the ER that their loved one had died, it's with empathy, but it's kind of cold, right? It's kind of regimented, especially, if they're older, it was expected because it's something that we do relatively frequently. With kiddos, it's uncommon, thankfully, and it's harder. And I think it's okay to show a little more emotion in those situations. So, one of our teachings in palliative care is, when you're breaking bad news, to generally not say I'm sorry, because it takes kind of the, all of a sudden the focus from the patient is on you, because the, good Minnesota, interactions, you go, you say I'm sorry, and the patient goes, oh, it's okay. And it takes away from their processing and their personal grief. But definitely when somebody has died, I always say I'm sorry. And especially if a kid has died, I think it would be okay to get, a little choked up, or, I think families take away from that you really cared and you really, tried your best. It's, getting back to who should be present in a resuscitation. Sometimes we worry that having family present to see all of the, invasive, blood, CPR, shocking, all of that can be traumatizing. And it was, studied a number of years ago that family members do better seeing that there's less, trauma after the event. And the thought is that they really take away that we did everything. They're not just hearing, hey, we did everything. They're seeing all of these people and everything that they're trying to do to resuscitate their loved one. And they come away from that not remembering, the CPR and the blood and the ventilator. They take away all of the helpers that we're trying to help.
And with that, something that we do in the hospital often that could be translated to the pre-hospital environment, sometimes the family doesn't want to be there for the entire 30-minute resuscitation. Those 2 or 3 minute pauses between pulse checks can become a little bit ominous or sort of uncomfortable for everybody there if they feel like, well, what else are we doing? We're just watching the patient right now. But I think it's nice sometimes to bring the family in during the last pulse check to understand that you've had the conversation. We're going to check their heart one more time, and if there's no heartbeat, and now we have ultrasound in the pre-hospital environment, and a lot of places show them that there's a heart there that's not beating. I think some of that can be nice, and it's a nice middle ground maybe that people could consider that we do in the hospital for those that want to be there for part of the resuscitation, but maybe not for the entirety of that.
And that's a situation where I use a number of years ago, as Breaking Bad News statement was developed. I wish, I worry, I wonder, and it's a really easy phrasing that I use specifically in the ER, and I teach residents this of how to break the bad news that you're worried that this loved one is going to die, and get to the question of, do you want to be present when we? So I wish things were different. I'm worried that we are not going to be able to get their heart restarted, and I'm worried that they're going to die. I wonder if you would want to be present at the time when we make that call, right? That is super quick. You're conveying emotion. You're getting to the nuts and bolts. You're not able to use jargon because it's so short, and you get right to that question. And it's a clear yes or no. And I find that most people do want to be present. And yeah, I don't know if that was answering your question. But.
Absolutely, yeah.
I would add a couple things because I love that. I wish, I worry, I wonder. I try to have family, if they're present, sit. And I try to have them sit where they can actually touch a foot, something. That sort of human connection, I think, is really valuable for them. I had a patient where the gentleman died and the wife was standing there, and she was a bigger woman, and she literally clutched her chest and keeled over. she ended up having a heart attack and a cut on her head and a bleed in her head. And I was like, okay, I don't think I'm going to tell anybody somebody's dead who's standing again for a long time, because you're going to see it all, and you're going to see all sorts of emotions. I had a patient once where when I told the family member they had died, they asked, could we get a second opinion? I said, well, there were 5 other doctors in the room. And she said, well, I still want another opinion. And I said, okay, why don't I take you in and you see him? And after you see him, if you still want another doctor to come in, we will do that for you. Sometimes you just have to sort of kind of go with the flow instead of trying to be, deliberate and pragmatic and saying no. Like, I mean, they just needed to get it out. Like, grief appears in so many different ways. So trying to be very kind and empathetic and sensitive, and there is no normal reaction.
I think this has been super awesome. We've touched on a lot of these things, and I think we've touched on a lot of the ways that we can do this well and a lot of the ways that we can do this maybe not so well. Seeing the residents that you teach, me being one of them, brand new interns who have never maybe even seen anybody die before, what are some of the things that you see as the most common ways that this can be screwed up or done poorly?
Oh, that's easy. There's so many ways. Like I said, I've done so many of them. One is taking too long to tell them the answer. One is not taking enough time to sort of give them that little warning shot. Well, he came and he wasn't doing very well. Some sort of warning that things aren't going well is very helpful. And I would say not using the died, dead words are very important. And using medical jargon is a big one. And then I would say trying to get away as fast as you can. Like, don't do that. Once you say somebody has died, I'm sorry to have to tell you this, but he died. Your job right there is to just be quiet and be present in a way of support for this other human being who just heard something that could be life-altering for them. And just take time there and let them process in whatever way they're going to process. And that might take a few minutes. And that's okay. That's part of your job, is to sit there and be quiet and not to rush out of the room. And in terms of pre-hospital, you don't have quite the resources, but we do talk about chaplain and medical examiners and things like that. But that can all wait. That doesn't need to happen right there. This isn't your moment to sort of check all the boxes of the care. This is a moment just to be present as one human being to another who's hearing some really awful news.
Dr. Schnicker, do you have any other potential pitfalls?
She touched on the big ones, right? It's, you have the Goldilocks rule, right? You can't have it be too long, you can't have it be too short. You're trying to hit that sweet spot, which generally you can hit in, 30 seconds, give or take. No jargon. And then I was just thinking of something right at the end of what you said, and
try not to do any blame. Right. Well, I wish you would have come to the hospital. So we brought somebody this past week who had been having some symptoms for weeks but didn't go in. And the family's like, he should have gone in. Don't comment. Like, it's not, like, it doesn't help at this point.
Oh, it's right. Back to silence is incredibly powerful, right? It's very uncomfortable for us as medical providers to oftentimes sit there in silence. But I've found through, our training that, patients and their loved ones fill that silence with usually profound and important information, right? They will talk when they are ready, and they will ask, thoughtful questions.
I would say, and similar EMS, you're wanting to get back into service and move on. So being silent and present is really good, but you sort of have to have a little bit of an exit strategy. Like, at some point you're going to have to say, we have to go. And so thinking about that during that silence is okay as well, just to say, okay, now how am I going to get out of here and get back to our work? And you need to process your own emotions about the whole case, because sometimes things don't go well. Like the IO doesn't go in right, they're esophagally intubated initially or something, and things don't go well. And I don't want you to dwell on those things. We all make mistakes and we move forward, but try not to let that get into any part of the conversation with the family. That's not when that should come out, if it's going to come out.
Yeah, I think that for me, the learning this and being new at this, I think the silence piece is really, really hard. We're used to going fast, fast, fast. We see a problem, we want to fix it. And sometimes it's really hard to just stop and say nothing. And for me, that was the hardest thing. And I think for a lot of people, that's the hardest thing.
And usually that silence isn't that long. It just feels like an eternity when you were sitting next to somebody. But, sometimes I'll watch the clock, when I'm in a big meeting in the hospital, and we're telling somebody that their cancer is beyond further treatment. And you sit there and it feels like an eternity. And it's really only 30 seconds, maybe a minute. I think we can all spare that. I've never had anybody take, 5 or 10, it's usually, they also, want to fill that space. And so it's surprising how kind of short that silence is, but how kind of profound and meaningful it can be.
I think that this conversation is a great starting point, and as part of this curriculum, I want to thank you both so much for being here and talking with me this morning. I think the most important part of learning how to do this well has to do with practice. And so for that reason, we'll have some practice scenarios associated with seeing 2 experts do this and how to do this really well. And so again, thank you so much for being here, and I really appreciate it.
Thank you for asking.
You're welcome. Thank you.
With that, I will release you all to your small groups, and we're going to go through some practice scenarios. I recognize that practicing and role-playing can sometimes be difficult with your colleagues, but this is how I learn, and this is what the data shows is the most effective way to practice these. And again, this isn't something that you'll master in the first 1 or 2 times doing this. This will take many months or years, even after many repetitions of doing this, to feel finally comfortable with this. And so we'll have some scenarios for you all to practice individually, and then we'll also have some example scenarios from our experts to show you how it's done extremely well.
Naz, I'm Karen. I'm really sorry. Things are not going very well for your loved one. John's heart seems to have stopped, and we're doing CPR and we're giving some medications, and we did some shocking, but things are not going well. The team is trying everything, but his heart's not starting.
Okay. He's not gonna make it, is that?
Well, I think you need to be prepared for that.
Okay.
We're going to give one more round of medications, and we're going to call the doctor at the hospital and get their input. Maybe we haven't thought of something and that we can still do, but I want you to be prepared that things aren't going well.
Okay. Was he in pain? Did he suffer?
I don't think so. I think he's really comfortable as we can make him right now.
Okay. There's nothing else you can do. You did everything.
I think we did everything we could.
Okay. All right. And he wasn't in pain the whole time?
I don't think he was in any pain or suffered in any way.
Okay.
I'm so sorry for your loss.
Yeah.
Do you have family we can call, or?
Yeah, I think it would be better if I called them. So what do I need to do now? What do I need? I don't know what to do.
So right this minute, just be in the moment.
Okay.
But then the police will be here, and they're going to help us figure out what the next step is for John.
Why is the police coming?
The police always come when people die outside of the hospital.
Okay. I just didn't know what to do. So.
Right. Of course not.
Okay. He wasn't even sick, so it's just came out of nowhere.
Tim, my name is Callie Schnittker. I'm one of the medics on scene here tonight. I'm sorry to meet you here. I understand that you called 911 because you were worried about your daughter.
Yes.
Yeah.
Yes.
So we got here and we found your daughter unresponsive. And I'm sorry to say her heart was not beating and she was not breathing when we found her.
Well, what are you doing now for her?
So we started aggressive interventions to try and restart her heart and her breathing. So we've been giving her medications.
How's she doing now?
So we've been here on scene for the last 30 minutes.
You said that. How's my daughter doing?
Unfortunately, despite everything that we have done, all of the aggressive interventions, your daughter has died.
Well, what do you mean she's died? You're still working on her, of course, aren't you? You're sitting here in my living room and all you're doing is talking to me. My daughter is down there. Why aren't you out there working on her?
I can't imagine how difficult
Why aren't you
this is.
working on her right now? She's only 30 years old. She was in perfectly good health this morning. What the hell are you doing?
We have done everything imaginable that we could do to
You've
try
quit
and
though.
bring
You
her
quit.
back.
Why have you quit?
I can hear how angry you are. And I can't imagine how difficult this is to hear and to be present for.
I can't believe this. I can't believe you guys just quit. I can't believe this. Take me to my daughter. Take me now.
We can
please.
take you to your daughter. Okay. Dawn, I'm Callie. I'm one of the medics here on scene. I understand, you were here when your husband collapsed. His heart stopped. We were able to restart it, but it's really important that we get him over to the hospital as quickly as possible. We're going to do everything that we can, but I think it's important that you call any family members that you might want to have at the hospital, because even though we've restarted his heart, I'm very, very worried about him. And I want you to understand how very worried we are.
I don't know if I understand, but okay.
Okay. We're going to do everything that we can. Okay. You drive as safely as possible to the hospital. We have to leave, immediately. Okay.
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 Okay.